So as I said before, we have now like 4 sessions that we're going to go through. So thank you. So this is the program for this afternoon. And then we have, actually it's like still morning for a lot of us, but okay. So we have, we'll start off with the screening of international cancer and prostate cancer with automatic and data retrieval with Kristin and Kristin. So the two of you, I would like them to just come up now. I will also introduce you a little bit more. So Kristin Oterholt Knudsen is head of the cholesterol cancer quality registry and from Cancer Registry in Norway. And then also we have Kristin Ranheim Randel, who's head of the colorectal cancer screening program, Cancer Registry of Norway. So thank you very much. You're going to stand here. So I'm just going to, yes.
Good morning, everyone, and thank you for the opportunity to come to talk about our experience with automatic data retrieval and for cancer and screening registries. These are the topics for my presentation. How we in the Cancer Registry of Norway has implemented SNOMED CT. Then I will give an example from automated data capture project. And last, I will talk about how we in Norway are working to develop and implement structural electronic health records for oncology. In 2023, around 38,000 new cancer cases were registered in Norway. The Norwegian Cancer Registry is a part of the Norwegian Institute of Public Health, and we organize the 12 clinical registries for cancer. We collect data from all over Norway. The purpose of the clinical registry is to help to improve the quality of healthcare provided to cancer patients. In Norway, cancer patients are examined at the hospitals. Once the examination is completed, the results are assessed in a multidisciplinary team meeting. And a decision is made regarding the treatment that the patient will receive. So now a little bit about data capture and data sources in the cancer registry. We collect data from hospital, national registries, and patients. It's mandatory for hospital in the fourth regional health authorities to report clinical information. And they mainly use our web-based solution for this, which means that they need to log on an external portal and read the medical health record and then report manually. But as an organization, we think innovatively and we continuously develop the way we capture data. So I'm going to show a use case a little bit later from prostate cancer, which is a good example of this. So how do we use SNOMED CT in our clinical registries? As a part of the work to improve data capture for clinical information, we had the opportunity to collaborate with the Norwegian Directorate of Health in their initiative to how we can use SNOMED CT in Norway. The initial project was the colorectal screening program, where there was a requirement for the reporting process to be structured and automated. The colorectal screening program is also organized in the Cancer Registry. In following projects, SNOMED CT has also been used in clinical registries for breast cancer, colorectal cancer, brain and spinal tumors, and prostate cancer. The process is learning by doing. When we're defining the setup, to set up the variables, we have both used complex ECL expression, post coordination, single concepts, and information models. Through this collaboration, we have built our own team with good competence in SNOMED CT. This provides us with a terminology that we can use as a common standard to harmonize our data and facilitate automated data capture. We were privileged to be involved in a pilot project in collaboration with the Northern Norway Regional Health Authority. And together with DIPS, which is the vendor of the EHR system in the northern part of Norway, here we wanted to explore how we automatically could transfer data from the EHR and into the cancer registry. In this project, there were developed 3 health record documents, and we were using common standards and terminology like OpenEHR, archetypes, and SNOMED CT. OpenEHR is a set of open specification clinical models and software that creates standards for healthcare. And the archetypes are detailed clinical information models defining using the OpenEHR specification. So here you can see an example from one of the documents and how they have structured it through the multidisciplinary team meeting. This shows how it appears in the clinician's user interface. It contains relevant information for the cancer type, so the clinician can decide on treatment choice. And it's also created a text summary, so it's possible for the clinician afterwards to edit the document. Then it's also made a report similar to what we have in the prostate cancer registry. Information from the MDT document and the outpatient document is extracted into the report, so they can send it to the clinical registry for prostate cancer. In the report, it's also possible to check if the data is correct, and the user activates the transmission and send it to the clinical registry. So in the process, we were also doing some quality check of the data we are receiving, and the hospital also get a feedback for our system that we have received the report. Here you can see the overview of the technical solution and the architecture from the EHR and to the integration with the cancer registry. So data is moved unchanged from the hospital in an IBXML message. And after we received the data, we need to do a mapping to our internal format. Then the registry manager can open the report in the database and processing the data. So what was the results of this project? Well, we see that the response time for data capture decreased from 140 days to 9 days. We know that time is essential for data quality, and real-time documentation is important. It was a success for the clinician. They think it's user-friendly and they save time. And we also see that the registry of prostate cancer, they have less requests for missing reports. An important part of the success was the involvement and the close collaboration with the clinicians. We had good experience with the model in the project, and this method of data capture is now established in-house at the cancer registry. And now the third example of projects that we are involved in. In connection with the establishment of the Norwegian Proton and Radiation Therapy Register, one of the mandates is to create structural electronic health records for oncology. Priority is first given to cancer types who are receiving proton therapy. A similar model to use to the one used for prostate cancer will be applied in this project. The purpose is to reuse information so the clinicians don't have to register it twice. It will create a document for admission, investigation, and follow-ups. So data can also be extracted for registers or research. So clinicians are here also an important part of the work. They are involved in determining the content in the documents, and the common agreement on setup is reached together with the vendors. The picture here shows the document for head and neck cancer, which is a cancer type that received proton therapy. And this is now implemented in the Oslo University Hospital. And several projects are going on for sarcoma, brain and spinal tumors, breast cancer, and colorectal cancer. So what will be the benefits of this health records for oncology? Well, a standardization EHR saves time, reduces work duplication for the clinicians, and so they can focus on the patient care. Structured data ensures uniform treatment standards and equal patient care across the regions. It provides reliable national homogeneous data foundation for research purposes, including elevation of proton therapy. And automated data capture provides quick access to updated patient information and improves decision support.
Okay. Thank you. Okay. So let's continue with one example. And just a disclaimer to start with, I'm not an expert on SNOMED CT. I'm a medical doctor. I work as the head of the National Colorectal Cancer Screening Program here in Norway, but I'm involved in the structured reporting of colonoscopy data to the registry. So Colorectal Screen Norway, I just give you a slightly background on that first. It's a service that was nationally implemented in 2024. We started in 2022. We invite males and females aged 55 to 65 by this test for blood in stool, occult blood test. So they do the test at home, the sampling at home, and then if there is a positive test, that means that they have blood in stool, that will be referred for a colonoscopy, and that is done at the hospital. And so there are different stakeholders and also different organizations involved in the screening program. And so the Cancer Registry of Norway is responsible of the administration of the program. That includes inviting people to screening, sending out these tests, remind people to do the testing, and also inform about the result. And also one important part of the Cancer Registry's assignment is the monitoring of the program, the quality assurance. That means not only the things that we do at the Cancer Registry, inviting people and having the participation monitored, but also the quality of the colonoscopies. And as I said, the hospital are in charge of the colonoscopies, they perform it, and they also do the pathology part, of course, and they do treatment and follow-up in case that is needed. So just a quick view of the flow in this part of the program. So as I said, Cancer Registry shown here. We refer the patient, the participant, to the hospital in case of a positive screening test. And then the examination of the colon is performed at the hospital. But in order for the Cancer Registry to monitor the program, we need data on the colonoscopies back to us. So the colonoscopy and the pathology is reported back to the Cancer Registry. And here I will talk more about the colonoscopy part. So in this project, we would like to capture the colonoscopy information to the registry. And there were some I call it demands, maybe it's a strong word, recommendations back in 2020 when we started. So the hospitals should use their own systems for patient appointments and also for documenting the procedures. There was a requirement to use the FHIR for exchange of electronic health data, and also common standards and terminology should be used. And then there was also a recommendation on automatic colonoscopy reporting. That means automatically retrieving information from the hospital system to the registries. And the goals, of course, was to avoid dual registration and reduce the need for manual registration, and also to keep high quality data, equal reporting, and also, as Kristin just talked about, the time, shorten the time from the procedure to the reporting. Well, this was back in 2020 and 2021, so there were a few challenges. For once, Jørn André told us about the dentist where everything was structured. This was not the case for the colonoscopy. Nothing was structured. That means some hospital had some structured way of reporting a colonoscopy, but most did not. So this was like free text. And I said at one point, I think there's just as many ways of reporting a colonoscopy as there were gastroenterologists at that time. So a couple of hundred ways of doing it. There were also no structured electronic health record system established at that time. And there were also several systems and providers in Norway, and still are, shown here in this map. There's a few less today, but this was the situation back then. And there was also, at least we felt that there was a lack of expertise in FHIR and SNOMED CT at the time. And we felt very alone when we started this work, but we were luckily very helped from what was the Norwegian Directorate of eHealth, and now the Directorate of Health. So we had a collaboration between the Cancer Registry and the Directorate and to start this work. And the first thing we realized that we need to describe what were the needs and make a specification. It was not only to put the SNOMED CT into some existing structure, we really need to make the structure. And then also, since there were not a structured health record system nationally, we also had to develop a temporary reporting software. But I will not go into that part, but that's another story. So what were the needs? Well, the clinicians needed to document the colonoscopy, the procedure, in the patient health record, the electronic health record. So that's like captures everything. Then there was some information relevant for the cancer registry, the screening information. Based on international quality indicators, we knew that we needed this information in order to monitor the program. The aim is to have a service that is equal in different parts of Norway. It should be the same quality of a colonoscopy performed here in Oslo as in the far north, for sure. And there is also another registry stakeholder in this project, and that is the National Quality Register for Endoscopies. Not only screening, but all endoscopies and colonoscopies performed in Norway should be reported to this registry, but they were not interested in the same, necessarily the same indicators as the screening program. It was a slight overlap, but also different. So all this had to be taken into consideration and captured in a structured form. And we made a specification. It was made actually on a very, in an Excel sheet with all the relevant variables, whether it should be structured or text. The patients are referred to a colonoscopy. The procedure is the same, but still there's so many differences between the findings, and you really need to be careful of what should be structured and what should be kept as text, because there's a limit of how far you can structure, and then it's a lot of clicks, but not really. If it could be captured in 1 word or 2 words, then maybe that's the easiest way to go. So, and there's also, in this sheet, we also captured the rules and the logics. So if that and that, then you can have these extra questions, and so on. And we also, to show this and anchor this with the clinicians, we made a very simple mock-up, a template, so they could see how it would look in a form, not giving them this very complex Excel sheet. So that's how we did it. And then it was part 2, mapping the SNOMED CT. As I said, this was a collaboration. It was a team at the Cancer Registry combined with a team at the Health Directorate. Identifying the medical terminology, because there's other terms as well. It's not only medical terms in this kind of reporting. Understanding whether there's other classification system like the ICD-10 that could, be used, and also the FHIR standard that was developed parallelly. Okay, so just to show you some results of this mapping of this colonoscopy report, there were more than about 250 terms identified in this Excel sheet. 179 were health-related, and 74% of them were mapped. And then there was several terms that were not health-related, like numbers, intervals. You see the examples here: yes, no, unknown, not applicable, size numbers. They were not mapped. And the reason for the health terms that were not mapped, some examples are given here. If it was specific to the screening program, like screening outside of the program, it was not necessarily mapped to SNOMED CT, and also specific variables for the context or Norwegian brand and so on. Okay, just to show you how this looks. So this is on the right side. You see the form that is displayed visual for the endoscopist. This is not very user-friendly for a GP to have as a report from the examination. So this is nice for documentation and registration, but then you made a readable summary, for example, to send to the GP after the colonoscopy. And then there was the other part, which is the reporting to the registry. And just to show you how this ideally works, when you have SNOMED CT in every step of the process, this is how it looks. We have it from the hospital system through FHIR at the cancer registry, in the internal systems in the cancer registry, in our warehouse where we combine different sources of data, and through the analysis and to the reporting back to the hospitals, back to the individual endoscopist. And of course, this is a with a slight modification. We know that not all the systems out there, the health record systems, have embedded the SNOMED CT in their system, but they map it out there. So in the FHIR, everything is that should be SNOMED CT is SNOMED CT. And we also know that at the registry, when we do the analysis, many use the STATA software, and actually the Norwegian national SNOMED CT codes have a too long string to be used in STATA, so we have to map it again. So slight modifications, but still this is how it ideally works. Okay, thank you.
Thank you very much. So thank you very much. Very interesting, of course, and this is good to see what we're going on through. As a respect to the other speakers, I think we have to move on, and then if there's any more questions, please save it for the break and to the lunch, and then we will then go on the program. So then we will have SNOMED as an engine for data-driven healthcare. And then I will ask Egil Gotaas and Marlen Toch-Marquardt to come up, and you also want to stay here, so thanks.
Thank you, Alfhild. Marlen Toch-Marquardt. I'm German as well as Norwegian, so and my name is not exactly perfect for Norwegians to to pronounce. So we are from Helseplattformen. Do I have a clicker? You have. We are from Helseplattformen. We are an electronic patient journal. And I first want to show you where we are situated. So today we are in our beautiful capital, Oslo, but we are situated further up north in mid-Norway. So I've learned in school in Germany that Scandinavia looks like a dog and Trondheim is the neck of the dog. So there, where you like to scratch the dog, there's Trondheim. And we have 720,000 inhabitants in mid-Norway. We have 42,000 health workers. We have 66 different municipalities. We have 9 hospitals and 170 GP offices. So that's what our base health service is in mid of Norway. Now I'm throwing my cards all over the place. This is how Helseplattformen looks today. We call it one solution for all. It's not all municipalities are with us, let's say, yet. We have integrated all 9 hospitals. We have integrated 34 municipalities. We have, for now, 2 GP services, 2 urgent care centers. 71% of the whole of the population of mid-Norway have a health record in Helseplattformen, and 39,200 health workers have daily access to Helseplattformen. All hospital labs, all hospital pharmacies are integrated into our system. And we have a link with the ambulances and the emergency rooms as well. So they are not actually using Helseplattformen, but they have access to information in Helseplattformen. So if you take the ambulance to a case where a person has a heart attack, and you go in as an ambulance worker, the first thing you do usually is you go into cupboards, try and find medication. But they actually now, they can go into Helseplattformen and find the medication of the patient they are trying to save. So they don't have to actually go through the cupboards and find the medication. Yeah. Okay, so that's a bit about Helseplattformen. And that's what we want to talk about today. So we kind of, as Jan did in the morning, we want to show you how we have integrated SNOMED CT into our health records on our system. And then we want to look a bit into the future. How can SNOMED CT actually help us to treat patients in the future? Okay, the first slide, this is how it looks in our solution. Here we have, that's like the first thing, we have structured documentation of diseases, of diagnoses in the system. It's findings and diagnoses. And that's how the system looks. And what we aim and what we have done is that clinicians are actually looking at SNOMED CT terms. So they are not looking into ICD-10 or ICPC2. They're looking at SNOMED CT terms, but the terms are of course mapped to different to ICD-10 and ICPC2. For example, ICPC2 is the primary care services diagnosis. Now I forgot the English word. Codewerk is a Norwegian word, so you just go with that. And we have, of course, mapped all the SNOMED CT terms are mapped to both, so that we actually have a link where the GP can talk to a specialist in the clinic without having problems of translation, because both are not, ICPC2 and ICD-10, they are not talking to each other. They are not the same. And if you just have the codes you do not talk, you do not collaborate. But with SNOMED CT, we actually have the possibility to have the data flowing directly from one clinician to the other. And here is for diagnosis. And we, of course, have structured documentation for nursing. So our nurses are using structured documentation, and we are documenting in so-called flow sheets. So that's what we are seeing here. And most of the rows in the flow sheet, so we have tons and tons of flow sheets. That's just an example. Most of the rows are mapped to SNOMED CT. And this, of course, enhances reusability of data. This enhances interoperability. So we have people in the hospital, we have people in communal care, in nursery homes, or even school health services. They all use the same flow sheets. And so we have the same exact same data for everyone. And that's not only increasing interoperability, but also data quality and the quality of care. And this is how, if we have a patient here who has seizures, and the nurse goes in and checks the patient for seizures, checks the medication. So here we have the points of where the flow sheet is taken in. Here we have the medication that the patient has received. And the doctor just can go in and check. He gets a report and can check how did the seizure develop over time in each and every patient who is there with seizures. So it's that's the reusability of the data, and that's how we actually can affect day-to-day work for a clinician and how we can improve it. And something we are going to talk a bit later as well is the medication, because we can also follow the medication with our system, and that's that the medication in Helseplattformen is based on the medical produce and not on the brand. So even if the brand shifts for a patient, we still can follow the medication without any problems. And that's our next slide. Oh no, that's patient plan. Gunnar is going to talk about that a bit later. We have, because we in Helseplattformen, we have integrated SNOMED CT a lot, and we hope that the rest of Norway is going to go our way. But we have one thing where we actually have it on a nationwide base, and that's patient plans. And we have integrated patient plans into Helseplattformen in different documentation solutions. And we have the different interface for all the users again, as we had before. And Gunnar is going to talk a bit more about the patient plans in Norway in the next presentation. And then one thing I touched upon already is the medication function in Helseplattformen. We have medication lists for each patient, and they are updated and available across health services in real time. So one patient gets a medication, and it will go into his health record, and if he goes back to his nursing home, for example, his medication that he has gotten in the clinic while being treated will be updated in the nursing home without any delay. Then we have a closed loop medication. This is the little drawing here, that the medication is administered. Then we will observe and evaluate if we need to change medication. Then we need to document the ordering. We dispatch the medication, and then we dispense it, and then it is checked with a barcode. So the nurse who's actually giving it to the patient will scan it, and then we have it have closed the loop, so no medication is going to a wrong patient, and so the security of administering medication is improved a lot. Yeah. And and just some further information. We use substance-based ordering. So we use generics. We do not use brands, but we use, now I'm not a clinician, so everything that I speak medically needs to be taken with a grain of salt. But penicillin is a group of antibiotics, and we just prescribe penicillin or on the group of penicillin that you're using and not on the brand. And that also comes into play in the future. If we actually need to exchange our data, then we can exchange on substance and not on brands, because brands differ internationally. And then we have generic prescription as well, so that, and that's also a law in Norway that the doctor has to use a generic product if it's available. So that reduces cost as well. And then we have decision support for medication ordering, and we have decision support for medication preparations on wards, and we have many forms of BPA or decision support, best practice advisory, and Egil is going to take over. Telling us about decision support.
My name is Egil Gottaas. I am a technical IT background, and I will go into a bit more detail on and behind the scenes how we use SNOMED in Helseplattformen. This is also an example for medication. We use, as Marlen is saying, SNOMED as generic products and substances. And we integrate, for example, with Felleskatalogen. It's a knowledge database for medication in Norway. We use SNOMED as links to that integration. So this integration is stable. Even if you get new brands, and then we have reporting to national registers. We had the cancer registry as an example of that. Then we also have the SNOMED ready for reporting without mapping. That goes for diagnosis as well. When we use generic products, it gets much more stable over time. And I guess in these days where we have new tariffs every day and probably a lot of changes in where you buy medication, it's very important that we have links that are stable over time. And this leads to less maintenance in the system and less of these broken links errors you see all around internet. Another benefit of using SNOMED is that we have the substances for on all medication. So when you have combination products, we have link to the different ingredients in the pill you're getting or whatever. And we also use the same SNOMED on registering patients' allergies. And using SNOMED this way makes the allergy warning more precise. So we see that we get, this is a measure of the override rate when the doctor gets a warning and they override and still give the medication. And we also see the reason. In most cases, they think the benefits is more important than the allergy. But this means that in about 60%, they actually change the medication based on the warning, and we have thousands of warnings. So this is really improving and giving patients better medication. And then we also have a lot of rules in the system. It's maybe thousands of rules, and rules is kind of if this, then do that. Yeah, and that can be to open a field or create a list for the doctors to choose from, or yeah, a lot of different rules. And especially on diagnosis and medication, using SNOMED really reduce maintenance cost and the effort to keep these rules up to date. Okay. So using the hierarchies, that will both reduce the number of rules. It will simplify them, and they will be more stable over time. And maybe also when we use SNOMED, both on the input and output side, we can start to share rules across systems and nations, so we don't end up maintaining all these rules in each EHR system, and that's really important because it's a lot of effort. We also use SNOMED when analyzing the data. Jørn André talked about that, but here we can see, do a search for diagnosed diabetes, and we see how many patients has diabetes in slice and dice, and then we can get the SNOMED hierarchy up and start drill down and see how many in the different groups or different more detailed diagnosis. This is also very helpful because using ICD-10, it's very hard to get an overview because it's so many codes. So finding the diabetes patients with ICD-10, you would list maybe 10 different ICD-10 codes. And yeah, so with SNOMED, it will be much easier to utilize the data. And it's back to you.
Thanks, Alfhild. And of course, no surgery without pain, right? So we have to talk a bit about challenges, and there are challenges. So we have, as you saw, we have integrated SNOMED CT, for example, in the diagnosis where the patients are, where the clinicians are seeing the SNOMED CT terms. And that comes with some difficulty for the end user, for the clinicians. First of all, it is we are going from free text, where clinicians like to write stories. I had a patient who had this and that, and then this and that, and we are not doing that in the same way anymore. Now we have structured documentation, and that was a quite big plaster to rip off, and it still is. And then we have, especially in Norway, I don't know how it is in other countries, but clinicians and doctors here in Norway are quite good and quite well versed in ICD-10 in using it, in using diagnosis groups, and they kind of feel that the terms are so different, and the terms are not what we are used to. Can we change that? Can we go back to our ICD-10 code boxes? No, we cannot. And that is quite difficult. And that is, we have actually to go to the clinicians and we have to talk to them. No, we don't want you to speak in boxes. We want you to speak in diagnoses. What is the patient failing or failing of? How, what are you treating? And this is, yeah, the difference between SNOMED CT and ICD-10. And we work closely together with the Health Directorate, and we had the discussion 100,000 times, I think, that the clinicians want us to use ICD-10 code names, but we can't do that. We don't want to do that. We are moved on. We have moved on. Of course, they are based, everything is mapped to SNOMED CT, or SNOMED CT is mapped to ICD-10, and of course, we are sending the boxes where they belong, but we want the clinician to think diagnosis, to think structured documentation. So that's, it has been quite an uphill battle, and it is going to be an uphill battle for some time to come, I think. But I think it's exciting. And then we have tried to map SNOMED CT to the Norwegian procedure classification, to also integrate that into our system. And that was quite problematic. We started on it, but it's quite a big project, and it's quite a lot of work that we haven't been able to do until now. But we are trying, we are starting with it, for example, the cancer registry, where we're actually trying to also map the procedures in the registry to SNOMED CT. So that's the challenges. And that was what we are doing now. So what is the future of SNOMED CT, or the future with SNOMED CT? And then, of course, we have to talk about EHDS. And we are going to have a presentation on that after lunch. So I'm not going to go into the political details. We just want you to show how SNOMED CT and EHDS would help us in Helseplattformen, or the clinicians, to treat a patient. So as I said before, I'm Norwegian as well as German, so I can make fun of Germans. We are not actually making fun, but we have an example case. And that's something that's happening. Trondheim is a beautiful city. We have a beautiful fjord. We have quite a few of cruise ships. And we actually have quite a few of patients who have a heart attack, something. I visited the grandmother of a school friend. She called me one day, can you go to the hospital? My grandma had a heart attack on her cruise ship. So I went there and just, translated a bit for her and brought her German books because she couldn't read Norwegian. So here we have Bodo Meyer, a German citizen. I must say he's a quite beautiful specimen. I tried Copilot to actually make him a bit obese, because he has underlying diseases like diabetes and high blood pressure, but the outcome was not very pretty, let's say it that way. So there's actually a bias. If you tell him, make him a bit obese, then you will get a person that is morbidly obese. So we go with this beautiful specimen, Bodo, a specimen, human being, but it's AI produced. So is it human? Is it a specimen? That's a good question. So he has several underlying diseases, diabetes 2, high blood pressure, and he takes several different medications each day. And he stops over in our beautiful town of Trondheim. We have a lot of cobblestones. We have a lot of rain and sleet, especially in April, May. So he just goes to our beautiful cathedral in Trondheim, which is the biggest one in the Northern Hemisphere. And he slides on the cobblestones and fractures his femoral neck. So he gets a hip fracture. And that's quite a terrible thing to happen to a person, because it's quite a big crush, and it's quite a bit, it has a big effect on a patient. The elderly patient who breaks his hip cannot, maybe not respond the same way, doesn't remember all the medication he's using. So here, that's what SNOMED CT can do for us. We get a list, a German list with diseases, underlying diseases, and you don't need to understand the German or Norwegian words, because we have SNOMED CT in the middle. And then we have medication, and here we have Obimed, for example. That's a medication you can't get in Norway. That's a Middle Europe specific medication. And then we see, okay, it's metformin hydrochloride. So then we can actually see in Norway, okay, that's what it's called in Norwegian. So that's what SNOMED CT is doing for us. We have a sick patient in Trondheim, we get the information from Germany, and we can translate it without losing any of the information. And this, of course, works the other way around. We treat the patient for his fractured neck of the femur, and we can report back. That's a very beautiful word, Oberschenkelhalsfraktur. That's a compound word. Germans love those. That's the same as zugrunde liegende Erkrankung, for example. It's also two beautiful compound words. And then we have the underlying diseases. And actually, while in treatment, our doctors in Trondheim, they found out it's not just a hypertensive disorder, but it's actually a systolic hypertension that the patient has. So we report back not a hypertensive disorder, but we report back systolic hypertension, systolic hypertension. And that could, if we didn't have SNOMED CT and if we didn't have the connections, the hierarchy, it would probably turn into two hypertensive diseases in German if we didn't have the hierarchy. But here the hierarchy helps us. Okay, it's systolic hypertension, but this is a child of hypertensive disorders. And this translates, of course, to hypertony in German. So that's what SNOMED CT can do for us if we are able to share our data. Future. So we have shown you a few examples of how we are using SNOMED CT, and I'm quite proud about that. We are one of the EHRs that I think in the world, but we are up there with with the extensive use of SNOMED CT in our solution. So we have shown you a few examples of present and future, but the possibilities are endless. Thank you.
So everybody, oh, thank you very much.
Thank you.
Thank you, Alfhild, and thank you, Marlen. So you also have you have a couple of questions for them, but we need to move on the program. Please keep the questions for the break, and thank you for a marvelous presentation. So now we will have the care plans and what's going on there with Gunnar Jårvik. He's gonna come up here and talk to us. He's a project manager from the Western Norway Regional Health Authority, and looking forward to what you want to say. Sorry.
I'm gonna need a manuscript on the screen. But hi everyone. My name is Gunnar Jårvik, and I'm a health informatician from the Western Norway Health Authority, and I'm here to show a dashboard really for nursing practice with standardized care plans and SNOMED terms. The Western Norway Regional Health Authority is the owner of the IT company that I'm representing, and they are also the owner of 4 public health enterprises and 7 private health enterprises is in non-profit agreements with the health authority, and they share the same EHR system. So in all 277 clinical wards in 45 locations are using the same system to see their data through a central data warehouse in the region. So this is all possible because of a common information model for standardized and individual care plans. Without it, we couldn't show a data warehouse with these elements. This is also necessary to be able to exchange care plans across implementations of EHR. But in our case, we don't need the FHIR resource because we have all these data in one implementation. And that is, of course, a good situation to be in. But it's also a problem because that means that we had integrated the standardized care plans in the system by making a copy of it. And we are also making copies of the terms. And we really struggle as administrators to keep these copies updated. So we really need a national infrastructure to exchange both individual care plans across technical implementations, but we also need a public library of standardized plans with SNOMED CT so that we can use FHIR to exchange these one standards on a national level. And today we're not there. So we are struggling with these copies in every region. We must work with that further on. The other point in this slide is that these vendors should really keep on using their proprietary data models on top of the standard one, because that makes the use, the application, the care plan applications much more useful, and the data is more comprehensible for the users. And I'm talking about the primary use of SNOMED CT. We've done this for, the project is 3 years old, and we've done it for 1.5 years, and we're going to get to the status of it. But first, I want to explain how the filters work. How is this possible? And the filters need a common information model, of course. And at the top, we see the organization that is really built on the National Health Directory of Health, common information model, and the so called it's a registry of medical units in Norway, RESH, registry. So that means that we can drill down to through the companies in the clinics, the medical departments, sections, and down to the basic clinical ward. And the other thing is that at the bottom, we have the priority data model from DIPS care plan. That is the plan element type, problems, goals, actions, and ordinations. And that makes it possible to show these split columns with the problem, goals, action, and ordinations through the in the dashboard. And we can even use funksjonsområde, that is the patient's functional areas, to filter these viewings. And the reason for monitoring the use of care plan elements is, of course, management insights from the start. That's where this started. And this is the third version of the dashboard, and now it's a multi-purpose dashboard. And I'm going to talk about the clinical unit improvement reason and cross-unit development. That's really much harder to succeed in. The managers and leaders are used to dashboards and for their insights. The nurses in the wards are not. So we're trying to put forward a program, a simple program, so that the wards will continuously be better at using the care plans and plan care. At this point, we're lucky because every hospital in Norway are obliged to doing continuous improvement. So we have this continuous improvement agents in each ward, and they have been invited to a regional group, and so we have a regional group discussing the use of standardized care plans and SNOMED CT, and they're giving working to improve it. And the dashboard corresponds with these steps towards better use of care plans. And this is where we have to understand the use of the reports from SNOMED and use of care plans is for primary improvement. It's not for secondary use. So this is the dashboard on the first step, use of plan, and we can see that there are, of course, an increase in the use over time, and we can see the evaluation notes that are connected to the plan elements also increase over time, and we see the users in blue and the users per plan element in green. So on a high level, this makes little sense, but if we put it down to each hospital, you'll see that the Stavanger hospital, they had a big bang implementation. They used DIP's classic care plan for 20 years. So they just migrated their system over to this and kept moving. And this is very different from the later hospitals of Førde, Fonna, and Bergen, who had more like a pilot phase going into a phased implementation of care plans. And they're still working on it. It works in progress. We're not finished. But this is the high-level overview for the managers. But if we go into more detail, we can filter out problems and goals and see that they start high and go lower. So they stop really evaluating problems and goals. And this, while the evaluating of interventions are more flat. So this could just mean that the practice is settling on evaluating the intervention in light of the problems and the goals of the patient. So this is the second step, reuse of the patient's earliest plans. So of course, this doesn't work unless you actually use the plans in the first place and the patient come back and has a plan. So from the start, this is really low, and we think that this will become higher further on. We can see the number of plan elements from earlier plans, and we can see a top 10 list, or best ward list of the wards and locations that are using the earlier plans much. And the psychiatric clinical departments are reusing the patient's plan much more than the somatic departments. And we can also see this list is, if you change column, you will get a different result, and we're not sure what's the right way to set up a good wards list, but it's up to the wards themselves. So to the terms, this is the SNOMED terms on the top level last 6 months. 466,000 should mean that in this year, 2025, we will have entered over 1 million terms in the EHR. 70% is coded, that means that 30% is free text. So we're not demanding the clinicians to use SNOMED CT. We're not demanding them to use standardized plans. It's more like guiding plans. But we can use this to show how it works. The psychiatric clinical wards are really much lower in the use of SNOMED terms, ICNP terms. This is the sad fact, and we think that's about usability. If they find this useful, they will use it, and if not, they will not use it, and we have a problem in the psychiatric wards. We can see that if the plan element is discontinued before the patient is dismissed from the hospital, there's a lower percentage with terms than otherwise. And we can filter this, use the functional area of the patient. This is sleep, pain, sleep, rest, well-being, and plan type problem. And suddenly the list makes so much more sense. It's a list of problems within a category, so I can understand what's it all about, and I find it much more interesting this way. And every time you use the filters, you get a heads up, this is the problem. And these are the SNOMED percentage of your view. And you can use this to find much interesting stuff, but in this case, I'm looking at the nutrition and nutrition in the psychiatric clinical wards, and I am looking at what they're doing in the psychiatric ward in this area, functional area. But of course, you can see that this doesn't make sense, because the percentage of SNOMED CT terms are so low. So I can't use this in any case. Any secondary data use is not applicable because of the low rate of SNOMED terms in this case. So moving on to guiding plans. The standardized plans in Norway are on the national level, we have 80 standardized plans, and we, in addition, in the Western region, we have 50 more. And in this prior system, we had 800 plans that were locally developed and really not kept up to quality over time. So now we are very strict. We only have regional plans or national plans. But you can see these star markings. That indicates that this is a regional plan, and it's made for efficiency, efficient planning, efficient documentation in the wards. And that's where most of the ICNP SNOMED CT terms comes from. That's the regional effective guiding plans. We can see again that the psychiatric clinic departments are using this far less, almost not at all. And the somatic is around 10 to 20%, varies between the hospitals. And yeah, you can see this trend is going in every hospital. They start with a high usage of standardized plans. So I think they work as training for planning and training for using SNOMED CT terms. And when they master it, they move on and use it less. That's for every implementation. And last but not least, this is the number of plan elements reused later on in the patient's trajectories. This is the top 10 list of the wards which has plan elements most reused other places, in other wards, on other clinics, other location and company and so on. So here we can see again that psychiatric wards are much better than the somatic wards. Actually, they are very much, they reuse their plans very much more. And what it shows again is that when I use the column other clinic and look at what's reused in the psychiatric wards, this ward list contains a lot of somatic wards. So the psychiatric wards are reusing somatic care plans, but not the other way around. So the point is to get to the last step where the patient receives continuous, wholesome, and high-quality care. But this is not something that we are able to just deploy as a tech project. We need to follow up the developing of benefits in the wards. It's a special project. I've never done anything like this in my work with EHR in 20 years, but this is far more clinical and much more interesting for the clinicians themselves. So we are continuing with organizing this as a clinical group, not a tech group. It's not a digitalization issue. It's an issue of developing good practices in planning care with good terms. And so far, we're novices in this, but our experience is very much that we must stop using IT to drive this and start using the clinician themselves. And that's the plan forward. Okay, thank you.
Hey, can you wait a little bit? Also a little present from from the Director of Health. Okay, so maybe to just stay up a little bit. So what I would like to do now, we have a little wrap up for this session. And before I will let you all run to the lunch, I would like us to, while I'm saying this, I think maybe Kristin, Gunnar, coming in, and Jørn André could come up again, and also so we can just have a little chat about these things. They are not prepared, so I know that they will think it's hard, but instead of me just wrapping all up together, I think it would like if there's some questions that you have in the audience, and also I will continue some of the questions that I will have, and then you can just tip into that microphone and run for the microphone if there are any questions. So we started up with Jørn André. You had a very interesting talk to us about dentistry and how you want the data flow from inside and then all the way to maybe actually do some research on the data. And that's very interesting to us. And that's one of the things that when we started up these things, could we actually make this happen? So a question for you would be like, what's the biggest learn that you would take from these projects that you've been involved in? Very hard, maybe.
I think what I've learned from that and from working with Helseplattformen and from listening to you, I also worked with Kreftregisteret and others, try to avoid making too much mess and fuss for the clinicians. And I think that's actually one of our success factors. We were able to, we kept them ignorant. Even better, can you keep them happy? Because that will eventually drive your data quality to a higher level than trying to make them do two work processes at once.
Fantastic, very, very good answer. So, and then for Kristin and Kristin, for the cancer registry and how you've been working on these things, it's been very interesting to see, and how that also make can help this automatically data change to be a little bit better than it was been before. So I wanted to ask you also, I mean, what's your biggest learn from this project, and what would you have done maybe a little bit more different if you had chance again?
Well, I think it's the collaboration with the clinicians and the IT developers and the vendors. It's a success, I think. So, and you need the clinicians on the team because they know what they want to document in the EHR. And as the cancer registry, we know what we want to us. But I think the clinicians are essential. And the teamwork in all of Norway with health authorities and the health directorate of health, and yeah, I think that's
very good too. We've been so happy to work with you. So, and that's but the thing is also we would like this to
and also the Helseplattformen
and Helseplattformen. So we would like this to be, you know, national, more registries coming on, and to make this, you know, happening for other registries. So so I think you're a very good example for it. So, and so for the Helseplattformen, there is, of course, we know there's a lot of obstacles on there, but you saying actually you would like it to be a part of a whole national thing, and you can actually see what's going on, and how you can actually ask to use these systems in another better way. And so I just wanted to ask you guys also, and what's the biggest learn that you would take away? Both of us are going to say. Yeah, go ahead.
It is a lot of work, so we had to go through all the medications and all the diagnoses and all the maps. So it's a lot of infrastructure work, but when you do that, then you will see the benefits, and I think we saw a lot of them today when you have done the groundwork. But it's a lot of work, and of course, what Jørn André said, it also affects the users.
Yeah. Do you want to add something?
Yeah, well, eat the elephant one bit at a time, right? You can't swallow the whole elephant, and keep your clinicians happy. That's important, and that's difficult as well. I know. Well, we know.
Fantastic. Thank you very much. So, and Gunnar, I mean, that's very interesting that what you've done to take this up and we can also see it now. It's more clear to see how care plans are really affecting, and how good it is for all of us that it's a part of it. And I know it's a lot of statistics and a lot of the tables, but you know, the true things that you're actually showing us. What would you say that would be the most important stuff that is taken out of this project that you've done with the care plans?
Well, it's really about usability at the end. If it's usable, they will use the terms of SNOMED CT in their system, and it demands more than just a good IT system. It will require a follow-up. It will require a continuous improvement on these on the use of the system, and that is really the work that the clinicians do. It's their main tool. Yes.
Well, thank you very much. Is there any questions in the audience? Yes, please come in.
Hi, this is Kai from SNOMED International. I had a couple of comments and some questions from our presenters from Helseplattformen. Thanks for your presentation. I thought it was really brilliant. I really felt like you were demonstrating excellence in a few of the things that you presented, you know, and kind of maturity and realizing some of the value of SNOMED as well. I was really impressed by, you know, you're kind of using preventative strategies like the clinical decision support and having that based on SNOMED. I do think SNOMED is, you know, should be an excellent foundation for clinical decision support. And we know, you know, some big vendors are doing it, but it sounds like you have got a kind of a national, you know, collection of these rules. Are they based on SNOMED directly, the national collection, or are you doing some sort of mapping? And my other question is, what sort of clinical decision support are you doing around drugs? Is it like drug-drug interactions or something else? The reason I'm asking is, you mentioned that it would be great to collaborate, you know, both nationally and internationally, and that sounds like a, you know, huge opportunity for, you know, so many nations to, you know, kind of copy what you're doing and realizing benefit from SNOMED, not just through interoperability, but actually, you know, something really powerful, preventing, you know, misdispense of drugs, essentially.
That was a very long question.
For the national guidelines, some are in SNOMED, but we haven't really gotten to that part yet to integrate that. But that's one of the things we want to do moving forward. And the other thing was. I was asking what sort of yeah, we have a drug interaction, allergy, dose calculations, and it's a few more, I think, but it's quite extensive. And of course, that's also could be too much. That's one thing we're sort of balancing the warnings and not get overloaded.
Okay, so
We have an online question for the Kristins. She first says, thank you for this very relevant presentation. Is your ambition to show SNOMED CT terms in the user interface for the clinicians? And if yes, will you develop suitable synonyms for this?
is this from?
I can try to answer, but well, in the colonoscopy form, there is Norwegian translation of the SNOMED CT, more or less. But of course, as I said in the presentation, not all the IT solution, the electronic health record systems have integrated the SNOMED CT. So yeah, it's a yes and no. But the idea is that it should be the SNOMED CT term that is visible for the clinicians, and that's how we worked and what we aimed for when doing this for the colonoscopy report.
All right, this one more.
Stefan Schulz, Medical University of Graz, Austria. I have a question and also comment to the second talk, and this was very amazing because you presented a term retrieval interface, which is very, very similar to what we are going to develop and roll out next year in Austria, namely code SNOMED CT and ICD-10 simultaneously. And you addressed the problem with phrasing. And I imagine that even perhaps it's in Norway even more difficult because you have two Norwegian dialects. You have a lot of clinicians from many other countries who have to learn Norwegian. So, so I understand that there's a bottleneck. Are you working on that to enhance the terminology, to add more synonyms, to perhaps allow English queries, so as to optimize the quality and the recall of terms which are being retrieved in this diagnosis coding process?
We work quite a bit on synonyms, but we also have some limitations in EPIC on how many synonyms we are able to load. So we don't really have the functionality to have the two Norwegian languages and maybe are patient-friendly or things like that yet, but that's something we want to do. But we also included the terms from the mapped codes. So I think we're now getting to quite, yeah, they're able to find the codes.
Okay, so I think we're ready to take to lunch now, and thank you very much, all of you, so very much. And then you're free to go and have a lunch.